Patellar tendinopathy is also called jumper's knee. The initial tendon injury is a tendinitis that is short-lived, maybe several weeks, but when extended for a longer period of time, the condition has evolved to a degeneration of the tendon or a tendinosis. There are both intrinsic and extrinsic factors that contribute to the mechanism of injury of this tendinopathy. Extrinsic factors include an eccentric overload. Think about during jumping. You have high eccentric forces that occurred in both the preparatory and the landing phases. This happens in individuals who have a lot of repetitive jumping activities. The eccentric overload may also be acute. Additionally, plane surfaces such as harder surfaces versus the softer surfaces may contribute. Harder surfaces are more likely to cause some type of tendinopathy than softer surfaces. Intrinsic factors that can contribute to this tendinopathy include dynamic valgus malalignments, altered patellofemoral joint compression, and decreased force production. In the acute stage, localized edema may be seen but is difficult to discern. Pain tends to be localized to the involved area of the extensor mechanism, and this is going to be dependent on the athlete. You will see it at the inferior pole, which is most common in jumping athletes. You'll see it at the superior pole in springboard divers, for example, and then it can also be found at the patellar tendon. Activity dysfunction is going to be stage dependent. There are 4 general stages of this tendinopathy. In stage 1, the individual will complain about pain after activity. In stage 2, there will be pain at the beginning of the activity, but it disappears after warming up and then reappears after the completion of the activity. This is why you will see a lot of basketball players, for example, that wear knee sleeves because they are trying to keep their patellar tendon warm. In stage 3, the pain remains during and after activity with the patient unable to participate in the activity. Stage 4 is the complete rupture of the tendon. There will be within normal active range of motion and passive range of motion knee flexion and extension. Diagnosis is usually done clinically, although people sometimes will have an ultrasound or an MRI. Counterforce bracing is often used. You can have a purchased CHOPAT strap, or you can create your own, which is pretty fast and easy. But in addition to the CHOPAT strap, you will want to train the quads eccentrically and increase range of motion for those individuals.